Sure, if we can start with my presentation, if you're able to put it up. Thanks. I won't be looking at the camera because it's hard to see in gallery view. I'm going to be presenting on safe supply. I want to have you guys understand the relationship between the opioid overdose epidemic and opioid prescribing, understand why opioid overdoses decreased in 2018 in the US and 2019 in Canada, be able to critically examine the evidence for safe supply, and understand the facts and assumptions regarding safe supply. So if we can move to the next slide. Next slide. Next slide. So we're going to start with a little bit of history. Arthur Sackler was a Madison Avenue ad agent. He started the Terramycin campaign in 1951. This was a direct-to-physician advertising campaign, and he made so much money off of this that him and his brothers bought Purdue Pharmaceuticals. If we can move to the next slide. In 1980, Jane Porter and Herschel Jick wrote a 5-line letter to the editor in the New England Journal of Medicine saying that addiction is rare and less than 1% with people prescribed narcotics. However, this was only with people who were in hospital. They didn't follow them up after hospital. This became lionized as an extensive study in Scientific American and a landmark study in Time magazine. This was quoted over 1,300 times by other scientific papers. If we can move to the next slide. In 1996, the American Pain Society president, Dr. James Campbell, said in his presentation to the American Pain Society, if pain were assessed with the same zeal as other vital signs, it would have a much better chance of being treated properly. We need to train doctors and nurses to treat pain as a vital sign. Also in 1996, OxyContin was released by Purdue Pharmaceuticals with the same techniques that Arthur Sackler used in the Terramycin campaign, quoting the 5-line letter to the editor by Porter and Jick. So what happened after this? We can move to the next slide. So this is a graph of overdose deaths in Ontario between 1991 and 2015. I'd like everybody to follow the red line. The red line is the number of overdose deaths with OxyContin. The next line that I want you guys to look at is the dark blue line. So after a while, OxyContin became replaced by fentanyl, and the number of fentanyl overdoses increased. If we can move to the next slide. This slide shows the relationship between the amount of opioid prescriptions and the number of prescription opioid overdose deaths. As opioid prescriptions increase, the number of opioid overdose deaths increased. We can move to the next slide. So roughly 21 to 29% of patients prescribed opioids for chronic pain misuse them. Between 8 to 12% develop an opioid use disorder. An estimated 4 to 6% who misuse prescription opioids transition to heroin. About 80% of the people who use heroin first misuse prescription opioids. So the take-home point from this is most people who use opioids do not start with heroin or fentanyl. They start with prescription opioids. And this is illustrated in the next slide. So one of the fundamental issues is that you have two groups of people. One group of people uses prescription opioids. One group of people uses illicit opioids, and there's an overlap in between. However, every year, 4% to 6% of the people who use prescription opioids transition over to illicit opioids. And when we increase the amount of opioids in the population, we have an increase of opioid use disorder. We can move to the next slide. So this was opioid overdose death rates in British Columbia. And what you'll notice is that there was a dramatic decrease in 2019. Why did this happen? We can move to the next slide. So we're going to focus on this part in 2019 in BC. But moving to the next slide, we're going to focus on 2018 in the United States. So this is from the New York Times, and it talked about how the total drug overdose deaths in America declined by around 5% last year, meaning 2018, the first drop since 1990. The decline was mostly entirely due to a dip in deaths from prescription opioid painkillers. Fatal overdoses and other drugs, particularly fentanyl and methamphetamine, continue to rise. So there was a decrease in opioid overdose deaths by decreasing the number of prescription opioids. Now, what happened in 2019 in British Columbia? We can move to the next slide. There was a decrease in medications such as opioids and benzodiazepines that can cause overdose. The next slide. There was an increase in the amount of take-home naloxone that was handed out. The next slide. There were safe injection sites. So these were very localized. They weren't providing the drugs, but this was a safe place for people to use. And the next slide. There was an increase in opioid agonist therapy prescribing. So all of these four factors, if we can move to the next slide. All of these four factors contribute to the decrease in overdoses in British Columbia in 2019. So we're going to go over the evidence for safe supply. If we can move to the next slide. So this is the statistics that are mostly touted by the people who are talking about the evidence for safe supply. So between March 27th and August 31st, 2020, 2,780 people received the risk mitigation, aka safe supply medications. Of the 2,780 people, 10 people died, leaving a mortality rate of less than 0.4%. So one big factor here is that half the people were prescribed opioids, about a quarter were stimulants, about a fifth were prescribed alcohol withdrawal management medications, and it's unclear why this was included in safe supply, and 12% were prescribed benzodiazepines. So if we can move to the next slide. So 0.4% mortality rate sounds like a good number, but if we break it down to the population level, how many people have an opioid use disorder? How many people have an alcohol use disorder? How many people have a stimulant use disorder? How many people have a sedative use disorder? So if you add all of that up and take the number of overdoses in 2017, the base rate of overdose death is 0.2%. So the rate of 0.4% that's touted in their study occurred over 4 months. So over 5 months. So it wasn't even 1 year. So you could expect that mortality rate to increase over a period of a year. The other thing that they don't reveal is what percentage of people in their 0.4% were on opioid agonist therapy. There were no comparison groups, and there were no objective measures to see if people were using less fentanyl. So this 0.4% that they're touting is actually higher than the base rate of overdose death in the population in British Columbia. So why do we need objective measures? If we can move to the next slide. There was a study in the Journal of the American Medical Association in 2012, and this followed, I think it was about 8,000 people over 6 years. And what they found was that high patient satisfaction was related to lower emergency department visits, but greater inpatient use, higher overall healthcare and prescription drug expenditures, and increased mortality. So the higher the patient satisfaction, the more people died. And this is why we can't rely on patient self-report to evaluate this program. We need to look at objective measures. So I'm going to go over some of the facts and assumptions regarding safe supply. If we can move to the next slide. So increasing the amount of prescription opioids available has known harms. It increases the amount of opioid overdose deaths, and it increases the amount of people with opioid use disorder. The benefits of safe supply are unknown. If we can move to the next slide. So proponents will say patients are looking for safer alternatives and consistent dosing for the substance of choice. We do not know if safer supply reduces overdose. The assumption is patients will use hydromorphone instead of fentanyl. So one possible outcome is the assumption is true and patients want hydromorphone instead of fentanyl. Another outcome is that it does not decrease fentanyl use and hydromorphone is used in addition to fentanyl. Another outcome is patients may sell safe supply to get more fentanyl. Another outcome is safe supply can be diverted, creating more addiction in the population. And another outcome is patients may use safe supply in harmful ways, causing more harm, like crushing and injecting tablets, leading to infections, vasculitis, and lung diseases. Any evaluation of the program would need to consider all of these outcomes. If we can move to the next slide. Proponents will say we are forcing patients into restricted treatment modalities when they are not ready for addiction treatment. So the assumption is that this approach will be beneficial for patients. So one possible outcome is the assumption is true and safe supply will keep patients alive. Another possible outcome is safe supply may increase risk of death for patients prescribed it, increasing exposure to opioids, increasing access to fentanyl through diversion. Another possible outcome is overall death rates may increase as more people become addicted to diverted opioids and stimulants. Any evaluation of the program would need to consider all these possible outcomes. And we'll go to my last slide. So this was from a CBC article, and this was someone who uses drugs and was prescribed safe supply. And he was saying that some days he doesn't take the pills, which is why a stockpile is building up in the supportive housing unit he lives in. Quote, maybe more than half of the people that I know
Sorry, doctor,
who are on these are looking to sell them.
Sorry, doctor, that was 10 minutes, but I see you got one slide, so
Sure.
maybe if you can wrap up. Thank you.
Yep, it was just finishing that quote. So there is a large amount of diversion taking place, but no one is evaluating the amount of diversion.
Thank you, doctor. That was a lot of information to cram into 10 minutes, so we appreciate your efforts. No, thank you for that. And I will now open it up for 20 minutes of question and answer with the members. Is there a member that would like to start? MLA Rosen.
Okay, thank you for the presentation. You mentioned the amount of people who are prescribed opioids, or I'm wondering if we can break that number down a bit. So for the
Sure.
people who are prescribed opioids, what percentage of those people develop an opioid use disorder?
So this is for chronic pain. And so between 8 to 12% of the people who are prescribed opioids will develop an opioid use disorder. So opioids are one of the top medications that are prescribed, and so a large amount of people are developing an opioid use disorder.
Okay, thank you. And then what percentage of people who misuse their prescription opioids transition to heroin after being prescribed?
So 4 to 6% of the people who misuse or who are prescribed opioids will transition to heroin. So this is the worry with Safe Supply, is that we're going to increase the amount of people addicted to prescription opioids, and then every year 4 to 6% of them will go and transition to illicit opioids, and that's the danger. We hear from patient groups that they don't like hydromorphone, they don't like the safer alternatives to opioids. Recently in Vancouver, I'm not sure if you guys are following the news there, they were handing out crystal meth, cocaine, and heroin. And they had people who use drugs rate them on a 5-point scale. And they were mentioning, people were rating the cocaine and the methamphetamine 4 out of 5, but they had much lower scores for the heroin. And the reason is people are used to taking fentanyl. They're used to taking illicit fentanyl. This is what is demanded in the drug market at this point in time. So it's unlikely that if we prescribe them these other opioids, that they're going to use them instead of fentanyl for recreational use.
Okay, and so you brought me to my next question, which is if 4 to 6% of people transition every year to heroin from their prescription opioids, at this moment in history, do you know how many people who are currently using heroin, or what percentage of people currently using illicit heroin started with prescription opioids?
80%.
Thank you. Just two more questions. You mentioned in the past, or I'm not sure what year it was, but there was a decrease in the number of prescription opioids prescribed, and that resulted in a decrease in deaths from opioid overdose. I'm wondering if you can just give us the numbers one more time on how much the prescriptions decreased by, and as a result, how much the deaths decreased by.
I have a graph showing how much it's decreasing by. So for opioids, it went from around 800 prescriptions in mid 2015, and then this dropped to about 550 prescriptions by July 2017. So there's been a reduction in time with opioid prescribing. And what I'm worried about is that we have made some gains by decreasing the amount of opioids that are prescribed in society, and we might reverse these gains by prescribing more opioids than we've ever prescribed.
Okay, and my final question is, you mentioned that the mortality rates amongst those who begin with prescription opioids or those who are using a safe supply system are higher than those who are not using such a system. I'm just wondering if you can tell us quite how much higher or how large that difference is between the mortality rates of the two systems.
So what they're using for evidence for safe supply, so this was the 2,780 patients, the mortality rate was 0.4% in 5 months. The base rate mortality is 0.2% in a full year. So the thing that they're using to tout as safe supply is working, I don't think shows the data that they think it's showing.
Just to be clear, the mortality rate was twice as high in a short period of 5 months as the baseline mortality rate.
It is. However, I mean, there has to be some caveats to that, in that the people who are prescribed safe supply tend to be sicker, but they're not measuring any of this, and there's not objective outcomes to see if people are using less fentanyl. Uh, and I don't really understand why they aren't using things like urine drug screens to see if people are using less fentanyl once they go on to safe supply. What they're essentially doing is that they're asking patients, is this program working for you? What are the benefits? And then they take that at face value, which really isn't how a lot of medical interventions are studied.
Excellent. Emily Yao.
Thank you, Chair. Dr. Mathew, thank you so much for taking the time to speak with us and our committee as we study this very serious issue. I have a few points I just would like you to reflect on and provide your answers to, but based on your presentation, there's a high number of people that become addicted to opioids and whatnot due to prescriptions. That said, these prescriptions are reflective of an inherent safe supply, I guess, we have already out in the system. Is that fair to say? And then how are our physicians in Canada educated in addictions? To what level? And are they at a level where they are recognizing these issues around prescription addictions to the prescriptions that they distribute? And do they work on weaning the patients off of these opioid potential addictions, if you will, on that? That's my first questions.
So there's a lot to unpack there. I was wondering if you can say the first question over again, that this comes from an inherent safe supply. I didn't understand the question.
A lot of the addictions seem to come from people who start off with prescribed medications from physicians. Mm-hmm. Say they have a hip surgery, they're waiting like 2 years to get that hip surgery because our system is pretty slow here in Canada, and they get addicted to those prescriptions. Is it safe to say that, technically speaking, there already is a safe supply out there? It's what we prescribe to our patients for their pain relief.
I think that's absolutely correct. Most of the people who use illicit opioids, so 80%, started with prescription opioids. And so there's two groups. There's people that these are directly prescribed to who become addicted, and then some of those people divert the medications and they're sold in the population. So when you increase the amount of prescription opioids in a population, you increase the amount of addiction to opioids, and you increase the amount of addiction overdose deaths.
My second part to that question was, are our physicians here in Canada, you work out of British Columbia, is that correct?
Yes.
Are our physicians in Canada educated to the point where they understand the opioid issues and are and part of their treatment programs for their patients are weaning them off these very same opioids that they prescribe, or is that somewhat questionable?
To be honest, I can't speak to the rest of Canada. I know for myself, I've given a lot of lectures to physicians and residents, and it is part of the psychiatry training program at University of British Columbia. I don't know what's happening with the rest of the training. However, the College of Physicians and Surgeons of British Columbia also has a standard of practice that physicians must follow. So there's been a lot of education about this, but I couldn't speak to the rest of Canada regarding this topic.
Thank you. My second question is follow-up, Chair. Is you had some slides there that talk about patient satisfaction, but that does equal a higher mortality rate. So is it safe? Are we basically saying that if we're just simply to rely on the patients who are addicted to these medications, that if we can't necessarily rely on their satisfaction and saying that they need to maintain these opioids, because ultimately it does lead to an increase in a higher mortality rate? And the reason why I ask this question is some of the groups that withdrew from our discussions here, our consultation process, that those are their arguments, that these people their loved ones would have survived had they just simply had access to clean drugs.
So I think it's even broader than the question that you're asking. In general, in medicine, when you look at medical interventions, you cannot rely on just patient self-report. You have to look at objective measures of benefit. This is why we have allopathic medicine and we don't have homeopathic medicine in Canada. The reason is we have randomized controlled trials. So if you look at the experience of human disease, most people that have diseases in general, like the broad experience of disease, will get better by themselves. So most people, their experience of disease would be the flu or things like that. So when you have an intervention, you have to compare a group that doesn't get the intervention to a group that does, because a lot of people who don't get the intervention will get better. So you have to see whether your intervention is better than the placebo group. Does that make sense?
Yes, sir.
Excellent. We now have Emily Amory.
Good morning, and thank you, Dr. Mathew, for your time and your presentations here today. I want to go back a little bit to some of the information that you provided in your slide deck. I know that 10 minutes is barely enough time to scratch the surface in this incredibly important area, and I wanted to kind of go back and have you highlight some of the things that you wanted to bring up in your presentation. Now, you've already illustrated that the relationship between opioid prescribing and overdose deaths are directly related. And that is, when we saw the chart that you had presented earlier, we saw where opioid prescribing increases, we see an almost corresponding increase in the total overdose deaths. I understand that overdose deaths is one factor for consideration. It's a metric that a lot of people place an incredible emphasis on, and I think for good reason. But I also think that there are other issues that we need to talk about as well. To be clear, I don't want to, for a moment, suggest that overdose deaths are not an incredibly important factor and the ultimate tragedy, if you will, but there are other impacts that I think we need to talk about, some of which you alluded to in your presentation. Now, the idea, perhaps, Doctor, is that safe supply reduces deaths, and I'm not sure in particular where the evidence lies in relation to that metric. But I want to know what other impacts we are seeing, and in particular in BC, where this safe supply model is being implemented. I think it's the best example that we have in Canada of a safe supply or quasi-safe supply model, and really the best jurisdiction that we can compare to other Canadian provinces for more information. Now, what we're seeing, I think, in your slideshow and in the key assumptions that you highlighted is that overdose deaths are not the only impact that we're seeing as a result of safe supply. Can you describe for the committee whether the evidence is settled that, in fact, overdose deaths are decreasing in safe supply jurisdictions like BC? And similarly, I want to give you an opportunity to comment on what trends and impacts that BC is currently experiencing that you may not have had a full opportunity to comment on during your slide presentation.
It's a very large question, and I'll try to unpack it the best I can. There is the issue with overdose deaths, but there's also the issue with addictions. So we had a case where there was a girl who was going to UBC who had gastric surgery. She was prescribed hydromorphone, became addicted to the hydromorphone, started buying the readily available hydromorphone, and overdosed several times, showed up at Vancouver General Hospital. And when she got to hospital, instead of starting her on treatment, they discharged her with a prescription of safe supply hydromorphone. And they kept doing this, and she kept overdosing. Eventually, she met up with a colleague of mine, and he started her on Suboxone. And she said that she would have started on Suboxone earlier if safe supply wasn't available. So one of the issues is that you can increase the amount of addiction in the population. And this has negative effects on healthcare costs. This has negative effects on the people of British Columbia. And we need to somehow try to look to see what the impact of it is. Because with safe supply, we have to look at things like overdose deaths. We need to look at the things of impact of addiction overall and the healthcare costs available to that. And we need to see what the net result of all of these issues are. But there doesn't seem to be any sort of search to see what the net effect is and what the net effect of diverted safe supply medications are in the population with a possible increase in addiction.
Thank you, Dr. Mathew. I'm going to yield my follow-up to another colleague who has a question for you.
So thank you, Emily. We now have Emily Steffen.
Sure. Thank you for that presentation. I thought it was excellent. I wanted to just, near the end of your presentation, it seemed that you had talked about how safe supply is sometimes used perhaps in inappropriate ways. In that, I know sometimes I've heard, my understanding is that individuals suffering under drug addictions are really looking for the next high. They're trying to get that high, and that the potency of safe supply is sometimes not good enough for what they are seeking, and that sometimes they'll use the safe supply that they're provided for purposes of a type of currency to get drugs that they think will get them that high, or they'll use the safe supply in a more intense way to try and again seek the potency that will give them that desired high that they're looking for. Can you comment in terms of studies of the use of safe supply as currency, for example, to get perhaps non-prescribed drugs, or when safe supply is used beyond the way in which it is prescribed or intended by the user of it?
So there aren't great studies on this. I did write a case study of a person who was convicted of fentanyl and methamphetamine distribution in the downtown east side. And he was talking about what happened before Safe Supply came in and COVID and what happened before. So one of the metrics that I found interesting was that he said the street price of hydromorphone tablets was $10. So an 8 milligram hydromorphone tablet was $10 before Safe Supply went in. At the time of the interview with him, which was in August 2020, the price of hydromorphone tablets had decreased to $2 a tablet. More recently, so within the last 6 months, it's dropped down to 25 cents a tablet. So now you can get 4 tablets for $1. So if people were consuming the safe supply that they were being prescribed, there would not be a drop in the street price of hydromorphone. With a hydromorphone being more available and cheaper, it gives more opportunity for people to use this for non-medical use and become addicted to hydromorphone over time. Some of the benefits of safe supply are sometimes when people are in withdrawal, they might take some of the safe supply to stave off withdrawal so that they can get so they can stave off the effects of withdrawal. But oftentimes what happens is people who are using safe supply don't feel that it's strong enough, and then they will sell their tablets for currency to get more fentanyl. The other thing is when they are using safe supply, they might not use it in tablet form. They might crush it and inject it, and that can cause a lot of issues with infections and other injection site issues.
Milken with about 2 minutes left.
Sorry.
Oh, sorry, Member Steffen, did you have a follow-up?
Yeah, very quick one. I'm just wondering, what's the BC government's response to the fact that there is this street price dramatic fall in safe supply medications? Because that sounds very serious to me.
To be honest, I don't really follow politics a lot, so I don't know what the response is.
Excellent. Emily Milliken, 2 minutes left.
Sure, I'll just ask very, very quickly then. Do you know of any studies that show that safe supply is associated with better outcomes, such as recovery for opioid users?
Not in the model that we have in British Columbia. So some of the things that they might cite are injectable opioid agonist therapy treatments that are found in places like Switzerland. But the problem is with the Swiss model, you do have injectable opioid agonist therapy, but you also have a lot of societal interventions, such as their 4 pillars model that includes treatment, harm reduction, law enforcement. So what they've done is they've taken that medication and they've taken it outside of the Swiss model, and they're just looking at the medication alone. And so we don't have evidence for that. The other issue is, the other example is John Marks. So he was a physician in Merseyside in the United Kingdom, in Manchester, and he prescribed heroin and cocaine in the 80s. None of his, what he was doing was not studied. There aren't published studies on this. However, it's very different than the safe supply model that they have in British Columbia, because in that model, they had the psychiatrist, they had a social worker, and they had the probation officer for the patient. And the patient would have to convince these three people every week that these medications were benefiting them. So we actually don't have.
Thank you, Dr. Mathew. That does conclude our time for question and answer. And on behalf of the committee, sincerely thank you for taking the time and for preparing the presentation and delivering it. So we really appreciate your time, and hope you have a good day.